Welcome back to MLT 130. This is the lecture on electrolytes. It's going to be divided up into two parts. Electrolytes are dissolved in our body within water and blood and produce an electrical charge and become ions. So where do we get electrolytes from? From our food, drink, and they're absorbed in the gut. Here are the objectives for this lecture. You can pause the video at this time and read through them on your own. The first electrolyte that we're going to discuss is sodium. Sodium helps regulate water in and out of cells, and that helps with muscle contraction and nerve impulses. It's the most abundant cation in extracellular fluid and makes up about 90% of all ions. Sodium has the greatest effect on osmolality. The extracellular concentration is greater than that of the intracellular. The reference range for sodium is 135 to 145 milliequivalents per liter. For a 24-hour urine, it's 40 to 220 milliequivalents per liter. Hyponatremia is where a patient has less than the normal range for sodium. So this would be less than 135 milliequivalents per liter for sodium. It's considered very significant or clinically significant if a patient has less than 130 milliequivalents per liter. So we have some different conditions listed here why there's an increased loss, or there could be an increased loss of sodium in some patients. So when this happens, there's not as much sodium on the outside or extracellular area. So there's more sodium on the inside of the cell. So what happens to compensate, the water or H2O travels inside the cell to try to compensate. And the red cells end up swelling because of that water trying to flow inside to help compensate. Hyponatremia can also be due to increased water retention, and these factors are things like kidney failure, nephrotic syndrome, hepatic cirrhosis, and CHF. These factors can cause water retention and dilute down sodium. Also, water imbalance can cause hyponatremia. Excess water intake and decreased ADH or SiADH. These two factors contribute to water imbalance. Some symptoms you might see with hyponatremia: if you see a range of 125 to 130 milliequivalents per liter, you might see some gastrointestinal problems. Below 125, you might see neuropsychiatric symptoms: nausea, vomiting, muscular weakness, headache, lethargia, ataxia, seizures, coma, and respiratory distress. Treatments for hyponatremia include fluid administration and treatment of the underlying cause. So it may be treatment of the kidney problem, the gut problem, etc., whatever is actually causing the problem. On the other side, a patient could be suffering from hypernatremia, which is an increase of sodium, which would be greater than 145 milliequivalents per liter. And it could be relation to water, excessive water loss or dehydration, diabetes insipidus, renal tubule failure, prolonged diarrhea, profuse sweating, or even severe burns. In hypernatremia, there is an increase in sodium outside the cell in the blood, so the water is going to try to rush out of the cells to create that equilibrium or to create balance, so your cells are going to shrink. Hypernatremia could also be caused by a decreased water intake, and this sometimes happens in our older patients, infants, and our mentally impaired populations. It could also be a result of hyperaldosteronism, which is an increased secretion of aldosterone, and our aldosterone is a hormone that helps with salt and water balance. Some symptoms that can be seen with hypernatremia for the central nervous system is a altered mental status, seizures, respiration difficulties, And with cases where there's a greater than 160 milliequivalents per liter, the mortality rate is 60 to 70%. For determination of sodium, our specimen can be serum, plasma, or urine. Hemolysis does not make a significant change to sodium values. Marked hemolysis may lower sodium due to dilution, though. Something really important to remember for our sodium specimens: do not collect in a sodium heparin green top tube. It already has sodium in it, so it will throw off your sodium value. You can collect in a red top tube or a lithium heparin tube. Do not collect in that sodium heparin tube. As far as methodologies for testing, we use the ISE, or ion selected or specific electrode. This is the most common method. It uses a semi-permeable membrane to develop a potential produced by having different ion concentrations. So basically you're just putting a probe into the sample and checking for concentrations. For the ISE method, there's two types. There's the direct and the indirect. The direct uses undiluted samples and the indirect uses diluted samples. There's some ISE methodology issues. There's some differences in results only with hyperlipemic and hyperproteinemia samples. Excessive lipids and proteins can displace plasma water in indirect methods, may cause false decreases in sodium results if have lipemic samples using the indirect method. A source of error is protein buildup on the membrane of the probe. The next electrolyte we're going to discuss is potassium. Potassium has an opposite relationship with sodium, and it has a role that is still involved in muscle contraction and nerve impulses. It's the major intracellular cation, so it's found in high concentrations inside the cells. So this explains its inverse relationship with sodium. It's 20 times greater inside the cells than outside, and 2% circulates in plasma. Potassium also plays a role in fluid balance and the sodium-potassium pump, sodium being outside, potassium being inside. Functions of potassium include regulation of neuromuscular excitability, heart contractions, ICF, which is intercellular fluid volume, and hydrogen ion concentration. Low potassium results in the flow of sodium and hydrogen into the cell, resulting in alkalosis. The regulation of potassium is done by the kidneys. The proximal convoluted tubule absorbs most. Then potassium is secreted in the distal convoluted tubule in exchange for sodium, which is under influence of aldosterone. And remember, aldosterone is a hormone that helps with that salt and water balance. Here are three factors that influence potassium distribution. The sodium-potassium pump, remember that's the exchange of sodium and potassium in and out of our cells. The sodium-potassium pump is inhibited by hypoxia, or hypoxia is low levels of oxygen. It can also be inhibited by hypomagnesium or digitoxin overdose. And digitoxin is a drug used for heart failure or irregular heartbeat. Insulin promotes potassium entry into skeletal muscle and liver by increasing the sodium-potassium pump. Epinephrine promotes cellular entry of potassium, whereas beta blockers block entry. Some other variables that affect the amount of potassium in our cells. Exercise releases potassium from our cells dependent on the amount of exercise. Hyperosmolality causes water release from cells, followed by potassium from cells. So potassium flows out of the cells. Also, cellular breakdown releases potassium. This can be from severe trauma or massive blood transfusions. A patient can be suffering from hypokalemia, which is decreased potassium. Some causes might be GI loss, renal loss, a cellular shift like alkalosis or insulin overdose, or decreased or just overall decreased intake of potassium. Or a patient could have hyperkalemia, which is increased potassium, and some causes could be decreased renal excretion, and it could be because of Addison's disease, a cellular shift, acidosis, muscular injury, an increased intake in potassium in the diet, artifactual or pseudo hyperkalemia due to sample hemolysis or poor collection methods. Factors to consider when you're collecting and running potassium tests. The process of coagulation releases potassium from platelets, so make sure you're using heparized tubes for collection. If the blood clots, you're not going to get an accurate measurement, so do not use serum tubes for potassium collections. Elevated platelet counts can affect potassium levels. If the tourniquet is left too long on the patient's arm, it can affect your potassium levels. And some hospitals or doctor's offices may ask you to eye samples to preserve the specimen. The determination is going to be the same as potassium. We're going to use the same test methodologies. We're going to use the ISE method, and we're going to use plasma and urine as our specimens. For the reference range for plasma, for potassium, the reference range is 3.4 to 5 milliequivalents per liter. For urine, it's 25 to 125 milliequivalents per liter. The next electrolyte that we're going to discuss is chloride. Chloride plays a role in the acid-base balance, helps with digestion. It also helps with balance of fluids with sodium, and it helps the kidneys maintain levels. Chloride is the major extracellular anion, so extracellular meaning outside the cell. Chloride is usually excreted in sweat and gastric juices and also urine. Some of the functions of chloride are not well understood, but it's involved in maintaining osmolality, volume, and electrical neutrality. Chloride ions are reabsorbed in response to reabsorption of sodium. It's reabsorbed along with sodium in the proximal convoluted tubules. And as I said before, excess chloride is excreted in sweat and urine. Chloride can be measured also in whole blood, urine, feces, gastric aspirate, sweat, in addition to serum and plasma. We can do what's referred to as a sweat chloride test to measure the chloride in sweat to diagnose patients with cystic fibrosis. To perform the sweat chloride test, we can use a chloridometer or a direct skin electrode. So basically, a chemical is added to the skin to stimulate sweat. The sweat is collected and put in a support medium or a filter. Then the sweat can be analyzed using techniques such as the ISE method or chloride titration. The regulation of chloride for patients, this is usually done with the diet because it's completely absorbed by the intestine. For clinical application, disorders for chloride are often caused by the same conditions that affect sodium. Chloride shift. The two major extracellular fluid ions are chloride and bicarbonate. They have an inverse relationship with each other. So we need to talk about metabolic acidosis and metabolic alkalosis. So in metabolic acidosis, you're going to have an increased chloride and a decrease of bicarbonate. So hyperchloremia, because extracellular bicarbonate is used up by a reaction with hydrogen ions, more chloride is needed then to maintain electrical neutrality. Therefore, the kidneys will reabsorb more sodium and chloride. So there's an increase in chloride, decrease in bicarbonate for metabolic acidosis. So this can happen through a loss like diarrhea. For metabolic alkalosis, this is hypochloremia. So you have a decrease in chloride and an increase in bicarbonate. So this is the opposite relationship. Again, decreased chloride, increased bicarbonate. Determination for chloride, the specimen, we can use serum or plasma for chloride. The methodology is ISE, is the most common methodology used. Our reference range for serum and plasma is 98 to 107 milliequivalents per liter. For urine, and this is a 24-hour urine, it's 110 to 150 milliequivalents per day. This is going to conclude part 1 of our electrolytes lecture. I will see you over in part 2.